welcome to our program, Our Community in the Opioid Crisis. I'm Vicki Lowe. I will be the moderator of tonight's event. I'm the director of the Foxborough Council on Aging and Human Services, and I'm also a member of an organization called Safe Foxborough. This is a town group that is led by our town manager, Bill Keegan, and the assistant town manager, Mary Beth Bernard. Also included for other town departments that are part of that group are the Board of Health, Council on Aging and Human Services, the Veterans Agent, Public Safety, and the School Department. Some of our community partners include the Rotary, some of our area churches, NORCAP, and the Safe Coalition of Franklin. Safe Foxborough's mission is to make our community safer, to raise awareness about addiction, and to provide information about substance use prevention programs that are out there. We also want to support and provide resources to people in need. Our program wouldn't be possible tonight if it weren't for Mike Weber, the executive director of the Foxborough Cable Access, and his great crew. People who know Mike know he's very talented and knowledgeable, and he's the one who's developed the format for our program tonight. It will be interactive if you're watching it in live, so you'll be able to ask questions of our panelists in real time. You can do that by logging on to Foxborough Cable Access, so it's fcatv.org/live, or you can go to Facebook Live, or you can email a question at info@fcatv.org. The message that all of us want to give you is that if you are having an issue with addiction, you or a family member, you're not alone, and we as a community are here to help. So I'd like to introduce our panelists. Stephanie Senna is a young lady who's in recovery. She has courageously agreed to come and tell her story in the hopes that she can be able to help somebody else and give them a message of hope if they're having a similar struggle. So welcome, Stephanie. Mike Kelleher is the Deputy Fire Chief of Operations for the Foxborough Fire Department. He has 20 years with the Foxborough Fire Department, 18 of those as an EMT and a paramedic. Jen Rowe is from the District Attorney's Office. Jen has a 23-year career as a district attorney. She worked as a prosecutor in the Suffolk County DA's office. And then for the last 13 years, she's been at the Norfolk County DA's office. She develops data-driven strategies to target the leading cause of preventable deaths in Norfolk County. Those preventable deaths are usually around opioid overdose, impaired driving, and violence in relationships. So we all know Jen, so welcome, Jen.
Thank you.
Dr. David Falling is not a stranger to Foxborough Cable Access. I can remember him being on our show way back when he was telling us about a new facility that was going to be built in Foxborough, and I think we all are very well aware of the state-of-the-art facility that we have right in here in Foxborough at Brigham and Women's healthcare facility right at Patriot Place. Dr. Falling is a primary care physician with Brigham and Women's. He's also an instructor for Harvard Medical School, and he's the medical director of the primary care practice in Foxborough. Dr. Claire Twark is a Harvard psychiatric resident specializing in addiction. This July, Claire will be starting an addiction psychiatry fellowship at Mass General Hospital, McLean Hospital, and Brigham and Women's. And Claire has been very involved in Stephanie's care, treatment, and recovery. So welcome, Claire. And last but not least is Wenwei Young. Wenwei is a licensed mental health counselor. She's been at Riverside Emergency Services for 15 years, and she's currently serving as the program director. So welcome all, and thank you so much for taking time to come and share your stories and tell about your resources. So let's start with Stephanie.
Hello. How are you guys tonight?
Good.
I always open with, I'm Stephanie and I'm an alcoholic and an addict. I'm just going to dive in and tell about my story, I guess. From a very young age, I guess, since I was like a child, alcohol and drugs I was very curious about them, I guess you could say. Alcohol, it was a common thing. It was around me a lot, you know what I mean? Like just, family parties, things like that. I was always very curious about it. But when I was a teenager, I didn't really start drinking or drugging until I got out of high school. Every time I did drink or drug, though, in high school, I got caught or something crazy happened. So that's how my drinking started. And once I entered into college, I basically made a conscious decision to drink and to use once I got up there, because I knew I was going to be kind of free and I could kind of create whoever I wanted to create, like this different person, I guess. I just didn't want to be who I was growing up. So that's the path that I wanted to take. And the first time that I ever drank in college, it was a blackout. I blacked out. And from then on in college, that's how it continued and as it progressed. But the people I hung around with, though, they were doing the same things that I did. So I never thought that this was a problem. I never, ever had any of those like moments of clarity, you could call them, where I thought like something was wrong with me or if I was drinking to excess or using to excess. I never thought that. I mean, it's funny, it's just because we all did it. We all drank like that. And as I look back, now, and just how irresponsible and out of control it was. The drinking obviously turned into drugging. Very quickly, it kind of went along with it, especially in college. And through my 4 years of college, I drank so much that I didn't finish school. And that's a direct result of my drinking and my using. I didn't want to do anything but party. And it obviously affected me because I spent 5 years in college and I never graduated. And this is years ago. This is back in like 2004, and it's 2017, and like it's definitely one of my regrets in my life that still bothers me to this day, that because I allowed myself to, I didn't allow myself, I had no control, and it's a regret basically. But as I left college, I came home and I did what naturally an alcoholic does, is I got a bartending job. And I was always very interested in bartending anyways. And some reason, it was another thing that I wanted to do when I was younger. I know that sounds funny, but bartending was like cool to me. And I thought it was something to get into, and I did. And along with the bartending came more drinking and more drugging. The late nights definitely had something to do with it, but also like the crowd and like that I hung around with and the people that came in. Like, I know this, sometimes instead of tips, I got drugs for tips. And, it just, I asked for it. I wanted these things, but it progressed and progressed and progressed. It got to the point where there was a substance in my body every single day. And then it came to the point where one day I discovered opiates. It's funny because I remember what I was wearing. I remember the day. I remember the weather. I remember who I was with, where I was, absolutely everything about it. And I remember exactly how I felt. And I thought that I had arrived, and this is what I wanted to do for the rest of my life. I wanted to feel exactly like that. So I chased that for a long, long time. I chased it and I chased it and I chased it. And through the years of the opiate abuse, things really started changing for me. I mean, it took control like early on, my alcoholism, and how much I drank, because I didn't finish school. I didn't do the things that I wanted to do, that I should have done, I felt like, which would be graduating from college. But not only that, but even more now, when I got into the opiates, it started changing me, like the person that I was. It started changing my attitude. My emotions were changing. I was a short fuse. I was very angry all the time. Very emotional all the time. I thought like something, I didn't know, like it still didn't click with me. Like I didn't understand. Like I tried to diagnose myself with all these other things, like, oh, I must have serious anxiety, and oh, I'm probably depressed. No, I have anger issues, and I have this and I have that. And but it got so bad, it was like where everybody else noticed it. My parents noticed it. People I worked with noticed it. My boss noticed it. Customers noticed it. I had regular customers, people who spent a lot of time there and telling me that they knew something was wrong with me. When I have an alcoholic telling me that you're an alcoholic or you're an addict, it kind of throws you off guard, and it's scary to hear. And I had major jackpots, like, throughout my drinking and using. Like, jackpots are where, like, something bad happens to you, where you think it would stop you, like, from drinking and drugging and wake you up. Like a normal person, we call normal people, like, who can drink in safety. Like, if something like that happened to them, they would stop drinking like they did. And I did not. Like, for instance, when I did have a moment of clarity one time. I had gotten out of work, and we went to a bar after work because it was open late, and I was using in the bathroom, and I must have gotten too high or something to where I blacked out, and I woke up on a bathroom floor in a dirty bar about 20 minutes later to people banging on the door, and it struck me, like it really hit me hard. And I remember saying, I was upset with myself. I was very, very upset, and I was visibly upset. I walked outside, and my friends were outside on the stoop, sitting down, like, chatting. And I came out and I sat down next to them, and I looked at my best friend dead in the eye, and I said, I think I'm a drug addict. And everybody kind of like laughed. But my friend was like, what do you mean? I'm like, I think I have a problem. She's like, what do you mean? What kind of problem? And I said, with like opiates, with pills. And, she sat there quiet with me, but I never spoke of it again. The next morning I woke up and it was all forgotten about. My roommate at the time, who I lived with for many years, like, she even saw the difference in my behavior, and like, she couldn't even stand to be around me anymore. This is my best friend in the whole world. She couldn't bear the sight of me anymore. So she moved out. Like, she couldn't handle it anymore. And she said it nicely, that she just wanted to move somewhere else, but I knew, and I accepted it, and I accepted this is who I am, and this is how it's going to be for the rest of my life. Okay. I accepted my addiction, but I didn't say I was an addict nor an alcoholic. I said, all right, this is how it's going to be. It's how it's going to be. So I continued to live my life like that. But I put down the opiates and the pills I was getting off the street. And I picked up a different, I picked up Suboxone basically, but I didn't get it from a doctor. I was told that they could help me, this and that, and I started taking Suboxone, and I ended up staying on it for 8 to 9 years, and I never picked up another opiate. But I was still drinking every single night and using other drugs every single night as well. And I considered myself clean because the opiates were the problem, not the drinking and this and that. Like, the thinking is what's crazy, you know what I mean? The way I thought, like, I put down pills, but I started taking Suboxone, but I'm still drinking every night, and I'm still doing these other drugs every night. It was insanity, absolute insanity. And it got to the point where I had to move back home now because money was disappearing, obviously. I couldn't afford rent anymore. I couldn't afford, I barely had money for my bills now. Like, it's just, I don't know how I survived all those years, like living in an apartment with an addiction like this and like paying all my bills and doing this, doing that. But, now I'm at home and, the years pass. I'm still doing the same old thing. My parents did find out in the midst of it that I had been doing drugs, and they confronted me about it. And when they confronted me about it, they did really well too. Like, the way they confronted me, like, they didn't like yell or scream. They sat me down, like, they had a nice conversation with me, and I kind of like let it all out to them. But I didn't tell them everything, I just told them that I had a problem with pills here and there. And now that I'm on Suboxone, this and that, and I get it off the street, but I want to get it from a doctor, this and that. And that's when I ended up going to Riverside in Norwood. And I spoke to somebody for a little bit, and they were trying to help me find a doctor. Because this was back in 2011 when the insurance wasn't quite where it was, and I made too much money to get Mass Health, so on and so forth. So I was having a hard time finding a doctor that would prescribe it, because back then a lot of doctors didn't. Only so many did, and they helped me a lot. Like, I got counseling there, and they put me in the right direction of where to go. And unfortunately, after that happened, I was arrested for having pills on me that obviously weren't prescribed. And that was another jackpot that happened. And I was thrown in jail for hours, and that still wasn't enough to stop what I was doing. It's crazy to think about it, because it didn't even scare me. I was more scared of the consequences at home with my family being disappointed. I wasn't scared about the law or what's going to happen to me, my record, and could this affect my future, and this and that. I didn't care. And then it just progressed. And then finally, and I say finally because it was bound to happen. It finally is when I started using heroin, and other harder drugs. And about a month after that, my life quickly spiraled downward very, very quickly. where not only like my attitude and my demeanor had drastically changed. Not only that, but my physical appearance had changed. I lost weight. My hair was falling out. I had cuts and acne all over my face. I didn't care how I looked. It got worse and worse and worse. And this is, and I just didn't care. This is when I was really in the midst. I just did not care. And I was with a friend, and she wanted to hang out with me for the day. She was acting really strange, and she kept telling me, she's like, let me drive. And we were driving on our way to my work, and she kept telling me to put my makeup on, and I didn't know why. I was like, why do you want me to put my makeup on? She's like, just try to look nice for work. And I showed up to my work in the parking lot, and my parents, my brother, my 3 best friends, and my boss were waiting for me in the parking lot, and it was an intervention. So I was like, oh, all right, yeah, because I look like absolute hell. That's why you wanted me to try to look a little better for my family, but I didn't care. And, they approached me and they said that, Stephanie, you're dying. You're gonna die if you keep this up. And I refused to listen. I kind of looked at them like they were like, this is crazy. Like, how aren't you guys how embarrassing for you to do this? But it's really how embarrassing for me. Because the way I looked and the only thing that was on my mind, not that I was an alcoholic, not that I was an addict. The only thing that was on my mind is they're like, well, Stephanie, we have a plane for you. We will take you to treatment, right now. There's a plane in 3 hours if you say yes to it. And the only thought that was in my mind was you know what? I've been on Suboxone for 8-9 years. I want to get off of it. And, it will be safe, you know what I mean? I can get off it in a safe way and I won't be wicked sick. And that was really my only thought why I said yes. So, I agreed to it. And next thing I knew, I was in Florida and I was in treatment. While I was in Florida in the treatment center, it was for about 40-something days I was in there. And it was kind of like the whole shebang, the rehab center. It was the medical detox. It was the education. There was outside fellowships that they taught you about. There were groups. There was activities. They did a lot for us down there. It was also holistic therapy, and it was pretty awesome. Massages, acupuncture, things like that. It was a pretty beautiful treatment center. And when I was down there, I honestly started to listen and learn that this was a disease. And and I really did. I listened and I learned a lot. And I was like, maybe I am an addict. Maybe there's something going on with me. And I ended up staying down in Florida. I entered into a halfway house and I did an IOP, which is intensive outpatient therapy, and lived in the halfway house. And in the halfway house you have requirements. You have to get a home group, like outside fellowships, and there's guidelines you have to live by in order to stay in the house. And I did all those things. I listened and I did all those things. And but the thing is I was still the same person, just sober, just with no drugs, no alcohol. But I always had in my head, I'm like, I can drink. I can have a glass of wine. I can have a cocktail. I'm in my 30s. I'm an adult. I can do this, you know what I mean? I don't have to be stone cold sober. It's just the drugs, you know what I mean? It's just the drugs. And I continued to stay sober for about 7 months, but basically I was a dry drunk. Yes, I was sober, but I didn't try to change anything about me. I was still the same person. I was still angry. I was still very emotional. I didn't try to get any help, like whether it was like psychiatric or, therapy or anything like that. I was the same girl with the same chip on her shoulder that was mad at everybody, but was really the person I was mad at was myself. And I didn't try to get any help. And so the day I got home from being 7 months sober and I moved back from Florida to back to Massachusetts, the day I got home, I used. And like my poor parents, they sent me to treatment. Like they did what they knew how to do, and they sent me to this beautiful treatment center. And I came home and just started using again. But that just shows the disease right there. Like I was still sick. You know what I mean? I don't know. And I started to use again, and I was drinking, and the next thing I know, I picked up a needle, and I was using heroin for a straight year. And this past year of my life, 2015 to 2016, it was the worst year of my life. Things went further down, even further down than before. I didn't think I could get any lower, but I did get lower. I did things that I never thought I would do. I acted in ways I never thought I would act. I didn't look right. It was horrible. And there was so many times where, I don't know, like you think a person would stop, but I didn't. I couldn't. I could not stop. It was insane. Like I can't explain like that feeling. Like nothing. It was never enough. It was never enough. And finally, after a month of, I was a mess. I was an absolute mess, and I had been in a number of car accidents in the past year, and it's a direct result from my using. Finally, I was in my car. I was alone, and I was driving down the road. I was like a 40-mile-an-hour zone. I was going 40 miles an hour, and I nodded off at the wheel. And I was alone in my car, but I heard somebody yell my name. It was probably my angel or something, but I shot up and I missed a telephone pole by, like a hair. And I pulled over because it scared me. Like I was shaken to the core. Like I was absolutely terrified. And all of a sudden, I had like a real sense of relief, and like fear left me, because I was like always so fearful and about everything and worried about everything all the time. And I just all of a sudden didn't feel that anymore. And I picked up the phone, I called my dad, and I said, "Dad, I'm in trouble. Like I need help." And he said, "Okay," and I got help. 2 days later, I was in NORCAP, actually. And once I was in NORCAP, I knew that things had to change for me. Not just staying sober had to change. Everything had to change about me. I used to say that I wanted this old person back, like the person I used to be, but like I don't even know who she was anymore. So I wanted to create a new person. And that's what I've been doing. And that's the journey that I've been on for this past year. And I called up my therapist and my psychiatrist, and they had been seeing me in the midst of my addiction, for like a year prior to that. But but yeah, because during that point, like, I'm going to rewind just a little bit. I'm sorry. When I first started seeing a psychiatrist and a therapist when I went to the Brigham is because I was extremely depressed. So depressed where, like I said before, my hair was falling out. I was 30 pounds less than this, and I wasn't eating. I was in such low moods, I couldn't get out of it, and they would occur for weeks at a time. So I was fortunate enough to start treatment with my psychiatrist, Dr. Tark, and my therapist, who was also at the Brigham. And once I landed myself in detox, like, I called them, and I was just so proud of myself that I finally went, because they knew how bad I was struggling. Because I was constantly missing appointments, and when I miss an appointment and I don't call, like, something's wrong. And they knew I was using and relapsing all over the place. Like, I just couldn't stop. I was in full active addiction. So I called them from detox, and I said, I really want to continue my treatment with you guys. And they were happy, they were happy to. And I did, and I stayed in treatment for about 11 weeks because I knew I needed it still. Like, I knew a lot. Like, there's so many groups that you can actually take and go to, like, in treatment. They're very repetitive, but, like, you do learn a lot. For me, it was a safety thing. Like, I kept myself so where I was in a safe place where I couldn't leave, and you know what I mean, and run out of there. To use, because if I right out of detox, if I went home, I would have, I can't say what I would have done. So I continued in treatment, and ever since then, I've been working very hard on myself, extremely, extremely hard on myself. Once I got out of treatment, like, I've joined certain fellowships, and I continued my psychiatric treatment and with my therapist, and it's going to be 1 year on June 2nd where I get my 1 year of sobriety, and that's within 15 years of using. This is the craziest thing in the world. I can't even believe that I'm going to be sober for 1 year, and I've changed everything. I've changed the people who I spend my time with. I changed my career. I stopped driving for a bit because I was afraid to drive because of I was a menace behind the wheel. And most importantly, I've changed me and what's in here, and I'm trying to, like, recondition my thinking. And now I have a year sober, but it's unfortunate when it comes with the sobriety, you also lose a lot of people. And just to show, I wanted to talk about this because something happened to me. I lost somebody about 2 weeks ago. And it's just to show, like, how scary this disease is. I lost my boyfriend. Well, he was my ex, but we were together for quite a long time, and he died from this disease. And it's happening all the time, way too much. It's scary, because if this was about a year ago or 6 months ago, God forbid, I would have been right there with him. And that could have been me, could have been anybody, But unfortunately, it was him, and I wish, I don't know, more resources, anything. I just wish that there was more out there for people. But yeah, but because of that, because he wanted me to see me sober, he knew that us together was a negative thing, and that, we were bad for each other because we used together and everything. So, I dedicate part of my sobriety to him, like I wouldn't be here, like if it wasn't for him too, and I am. So I choose to chase that till the day I die, because I'd rather live, live a healthy, constructive lifestyle other than the life I was living. But yeah, here I am 1 year later, so that's it.
Thank you so much for sharing your story, Stephanie.
Okay, you're welcome.
Mike, do you want to tell us what's happening in Foxborough right now?
Absolutely, yeah. At first, I'd like to thank you for inviting me to be here. I'd like to thank Stephanie for agreeing to do this, and I admire your courage. It's an important topic. But, first of all, I'd like to just point out we put some definitions together for the people at home that might not be familiar with some of the terms we're talking about. So we've kind of defined Suboxone. We'll talk a little bit about what Narcan is, or naloxone, which is a medication used to treat overdoses. We'll talk about fentanyl, which is something that's kind of relatively new in the world of illicit drugs the last couple of years. I think one thing in Foxborough, I don't think people actually think it's here. I think they do now, but the reality is it's been here for quite a while. Yeah. I think that's one thing. People turned a blind eye to it. They thought there was, that it was somewhere else. It was in a city. It wasn't here in Foxborough, but the reality is it was, and it has been, but now it's getting the attention, I think, that it needs to combat this epidemic. The average age we see in Foxborough is 34 years old. We've seen people as young as 16, and we've seen, unfortunately, we've seen elderly people. I think Jen's going to talk about, the path of how, this opioid epidemic kind of came to fruition with, prescription medication, and then, getting pills on the street, and then heroin use. I think that's a common thread we see in a lot of people, but, unfortunately, there's no socioeconomic barriers, there's no demographic. We see poor people, rich people. It's across all boundaries. So sometimes here in Foxborough, we'll see multiple people on a shift if they're getting a higher dose of, it's not regulated. Heroin's not regulated. When you're buying something off the street, it's not like the FDA is approving it. So, whoever's mixing the stuff up, sometimes it's stronger, sometimes it's weaker. So it's very hard to regulate that. So, sometimes we'll see the same person overdose. We've seen the same person overdose 3 times in 24 hours. That's unfortunate. Narcan is effective, but with this new fentanyl trend we're seeing, it's exponentially stronger heroin out there, and it takes more Narcan to turn an overdose around. So they're using fentanyl to make the heroin stronger, and it's a new phenomenon we've been seeing in the last couple of years. I know there's been some news cases recently, one in Ohio the other day, where this stuff called carfentanil, which is used. It's a large mammal tranquilizer. They use it to tranquilize elephants and things. That's out there too. That's exponentially stronger than fentanyl. So you're seeing these new things. It's it gets stronger and stronger all the time. So unfortunately, we had about 1 death a month for the last 6 months of 2016. We've had 2 or 3 this year already. So it's here, and I think getting together like this, the group that we belong to, I think is important as we move forward. So.
Did you want to say anything about the safe disposal of the kiosk?
Thank you for reminding me. Yes, we do have a kiosk in the lobby of the Public Safety Building. It's located at 8 Chestnut Street. It's right in the lobby. It's off in the corner. It's you can come and you can drop your medications off. It's safe for all medications. I think one of the important things that will probably come up tonight is that's a source of drugs. People get prescribed things, whether it's they have a tooth extracted or they have a knee surgery, and these things are hanging around the house, and that can be dangerous. It can fall into the wrong hands. So I think it's important that people dispose of medications. They don't leave those hanging around. And the Foxborough Public Safety Building is a place you can dispose of those medications free of charge.
So Jen, do you want to tell us about some of the programs that you're involved with?
Yes, and also likewise, thank you very much for inviting me to join you here today. I think that Foxborough already, certainly a community very rich in resources, but the addition of your coalition and the work that you're doing and the partnerships that you've built, not only through traditional partners in law enforcement and first responders, but in healthcare is really going to make a significant difference in working on some of these issues. And I think Foxborough should be very proud of what you're doing. So thank you for that. I also wanted to say thank you to you and to your, Foxborough Police and Fire for the work that you're doing and really rushing to scenes to save lives with naloxone. The number of successful reversals that we've had in Norfolk County, which is the first county in this nation to have naloxone in every cruiser, engine, and ladder, is really staggering. So the data that I'm going to share with you in a few minutes about what we're seeing in terms of fatal overdoses in Norfolk County is offset by the lives saved, hundreds and hundreds of lives saved, thanks to our first responders who were willing to add one more thing to the list of so many that they already do to help us in our community. So when there's a 911 call, here in Foxborough, police and fire are rushing to the scene with naloxone, ready to reverse that overdose. And I also want to say thanks to Stephanie for having the courage to share your story. The data that I'm going to share is numerical, but to put it into a context with a beautiful young woman raised here in Norfolk County, too modest to mention that she is an exceptional athlete, played soccer in college. I think that's important for families to hear. This isn't something that can't happen in your family because you're doing all the right things, because that was exactly Stephanie's childhood. And really, the work that we're doing is to try to highlight that much of what we're seeing is happening because of access to pharmaceuticals. I think there's a bigger appetite and interest in talking about addiction when you think about healthcare, and hopefully some of the information that I'm going to share with you will do that in your family and in your community and make a dent in what we're seeing. District Attorney Morrissey had the foresight to develop a review of all fatal overdoses that encompasses the 28 towns that make up Norfolk County. We actually just met yesterday. And I'm very sorry to share with you that so far, from January 1 to April 30 in Norfolk County, we had 62 fatal overdoses. So our numbers are going up despite many of the data-driven strategies that we've implemented to date in Norfolk County. The data that I'm presenting on the slides really speaks to last year, 2016, when we had 172 fatal overdoses. I've included data back to 2013 because that was the year that I applied for a federal grant that awarded funding to locations that were particularly hard hit with overdoses. There were two locations on the eastern seaboard that were funded. One, Manhattan, and the other is Norfolk County. So when you think about the scale of our problem, we're smack dab between two healthcare destinations, Boston and Providence, and we found ourselves with a significant problem with opiate overdose. The review process is really one that pulls together our traditional stakeholders and also our new partners through the Board of Registration Medicine and Pharmacy and Dentistry and Nursing, and so both from the prescribing and dispensing side, and also to take a very close look from a source investigation perspective for illicit drugs. What we've seen is that most overdoses in Norfolk County are pharmaceutical and involve medication prescribed to the decedent. We take a look at and break down the data to get a sense of what our most vulnerable populations are. And of the 172 deaths last year, 133 were men. So Stephanie's story is a little unique in that the typical profile of someone who we see in a fatal overdose is a white male, late 20s, early 30s. obviously living in one of the 28 communities, but there are some that are more harder hit than others, some of our more denser urban communities. But Foxborough isn't an exception. None of the communities in Norfolk County are. The youngest decedent last year was 17 years of age. It was the first time we had a high school age student die of overdose, which was devastating. I'm the mother of a 17-year-old and a 19-year-old, and that really took my breath away. To think that we still have kids who are in our school population with all of the resources that we have, with so much ahead of that young man, and we lost him to overdose. I've included that 78 of those overdoses were to individuals under the age of 35. So when we look at the medication that's prescribed, particularly opioids, to individuals without who aren't being treated for cancer or end-of-life pain, it really does take your breath away. And that's something that we've focused on and spent a lot of time on in terms of the strategies that we're implementing. And again, virtually all of our communities had a fatal overdose. 26 out of the 28 towns had an overdose last year in Norfolk County. In the review process, we look at reports from local police. So there's a 911 call. Local police respond, and if that individual dies, it triggers the response of the state police assigned to my office. The richest source of information comes to us from our local police reports. In so many instances, we have police officers who are proudly serving the town that they grew up in. They might have known that beautiful young kid and grown up with their parents and coached that individual as a child, and so they take the time to ask questions about how that struggle with addiction began, how there was access to pharmaceuticals, and we've learned a lot from our local police departments. And I've listed for you some of the things that have caught our eye in this in the review of fatal overdoses in terms of risk factors for school-aged children. The greatest and most common thread that we see is really prescribing postoperatively to teenagers following a sports injury during their high school years. And that my kids have done a fantastic job with sports injuries. We know from healthcare so frequently that patient doesn't go back to see their surgeon, but we do know that following orthopedic surgery, we see physical therapists and a high school athletic trainer. And so we've partnered with those individuals to really sort of help identify, along with school nurses and parents, who might be at risk in terms of struggling with addiction following that injury. What happens is you have an athlete who has a devastating injury, who isn't able to play with their team, and while this wasn't the case with Stephanie, a lot of those feelings of depression that go along with addiction come in the deaths that we review because they aren't a part of the things that make them feel good about themselves. And so if we, as school leaders and those with a medical role in our schools and communities, can help identify kids who are struggling in that scenario, we're a lot better off. We don't see much associated in terms of prescribing following oral surgery, but I've included it on the list because I think certainly the frequency of oral surgery among teenagers, but also might not be as noteworthy to parents as that devastating sports injury. So we believe that it might be more significant in terms of initial access than the reports indicate, but I've included it just because it's a time to be super vigilant as parents when your kids are being prescribed Vicodin and Percocet following oral surgery. The other risk factor is lowered tolerance. If you think about Stephanie's story, she certainly was very fortunate to survive the use following the 40-day hospitalization in Florida. So to use the day after returning from rehab is what we would call a lowered tolerance scenario. Mm-hmm. We look at release from incarceration or release from rehab the day of death or day before, and for example, in our overdose death review yesterday, 11 of those individuals died in exactly that manner. Lowered tolerance because you're confined in a situation where you can't use, and when you're released and you do use, you can't handle the amount of drug that your body was able to handle before. And so that's really what we're focusing on for young individuals. We have developed some really important work with our school leaders following the passage of Chapter 52 of the Acts of 2016, which is Governor Baker's opioid law, with SBIRT, which is a screening for substance use, but really targeting our high school athletic trainers so that when a student athlete is returning to school in sports, to be able to also ask those questions while you're talking about, range of motion and management of pain while playing, but also questions about managing your medication and be able to assist that athlete when they're returning to sports. Also, I think important for parents of high school aged students to know is that the drugs that Stephanie used and that we see in our overdose death review are so strong that we're seeing a lot of teenagers who are struggling with addiction from a very early age and very close in time to their initial access to that drug. Our kids have grown up in a culture of zero tolerance, really. In school, and they have such a high price to pay when they find themselves in violation of chemical health rules and the student handbook and the consequences that are triggered through the MIAA. That a year ago I wrote a rule proposal change to the MIAA chemical health policy, and it passed. And so now student athletes in Massachusetts can approach that trusted coach or teacher without penalty. And prior to a violation of the chemical health rule, ask for help and not miss 5 hockey games, for having the courage to step up and say, while I'd like to think my kids would come to me, they might very well go to their coach or their teacher or someone special to them in school. And our kids need to know that they can do that and that they can do that without penalty and remove some of the barriers and penalties that our kids are facing so we can really help them. And I hope that I feel that it's our responsibility to share that with kids, and hopefully that will make it easier for those who are struggling silently, to really take advantage of that. And all of the, NORCAP and Riverside and the Brigham and Foxborough, what incredible resources we have. But if kids are too afraid to ask for help, then, we're not even accessing all that we have. In terms of risk factors for adults, lower tolerance is obviously one of them. One thing that we see that is staggering to me is the number of individuals who are engaged in medication-assisted treatment who are also prescribed overlapping benzo and opioid prescriptions. So when you review the patient prescription history of that decedent and you see regular monthly intervals of prescribed Suboxone, and then you also see opioids and benzos, and recently we've seen a significant uptick in amphetamine prescriptions on top of that. That's the typical overdose scenario for pharmaceutical overdose in Norfolk County. And the amount of medication really makes you wonder, how did that beautiful young person live as long as they did in receiving some of those prescriptions? Prior reversal, prior save from our first responders is also a risk factor. So one thing that we've done in that situation is really we've developed a response called the Norfolk County Cares Kit, where when our first responders arrive at a residential location and they save a life, we provide those family members with resources so that when their loved one returns home from the emergency department, that they have information about support for themselves, access to treatment. We provide a sharps container, and all of that information is really intended not for the individual struggling with addiction, but for those who love someone struggling with addiction. Information about a program that the Mass Bar Association started to sort of level the playing field in Section 35 petitions, so that petitioner, that parent, Stephanie's parents had the wherewithal to ride out her recovery despite some of the things that happened along the way. They never gave up. And filing a Section 35 for a parent is probably one of the hardest things that you have to do, to have court-ordered involuntary hospitalization. And what you see in court is that the individual struggling with addiction has court-appointed counsel, but the parent who's trying to figure this out has no representation to assist them. And in Norfolk County, the Mass Bar Association, through the hotline and in the information that is contained in the Norfolk County Cares Kit, will have a lawyer there for anyone who is filing that petition at no cost to assist you through that process, because not being hospitalized isn't necessarily a win, right? The goal is saving a life, and through that really forward-thinking initiative through the Bar Association, I think they're really doing a fantastic job. Another part of the kit is to provide the public with access to naloxone. So you can walk into your pharmacy and you can get naloxone. It doesn't have to be for you. There are some who originally thought, well, if it's going through your insurance, that drug must be for you. That isn't the case. But what we found is that many individuals are afraid to make a request for Narcan or naloxone. You've got 20 busybodies waiting behind you in line at the pharmacy, and you don't want to have that conversation. So we've provided a document where you can fill out all of the information, hand it to the pharmacist. You don't have to have a conversation out loud, removing the difficulty of having a conversation with the pharmacist and saying, this is what I need, and really putting it out there. And I know that Foxborough, probably within 5 minutes of getting that document, has the widest spread of that information across this incredible community. So Vicki, thank you for what you did. It was, I think I sent it to you in email, and literally within 5 or 10 minutes heard from so many different community agencies saying, I'll put it in the library, and I'll put it here, and I'm going to stock it here, so that really the public could access naloxone with ease and make their households and ones that they love safer. Another project that we're doing is safe storage and disposal, and we certainly ask everyone to support us in that effort. There's a lot of medication sitting in homes that doesn't need to be there, and so you can go obviously to the lobby of, as you've heard, to the kiosk that's there, no questions asked, drop off medication. You can do that in any police department in Norfolk County and dispose of that medication, and then the police departments then transport it up to Covanta, partner of ours, clean energy business, and they safely destroy that medication so that no one else can access it. So I think the real message and what I hope that comes along with the unfortunate numbers that we have is that with the resources that we have, particularly here in Foxborough, but across Norfolk County, is that there's so much that can come from taking advantage of not only calling 911, getting your first responders there, having naloxone in your house if someone's struggling with addiction, getting the medication out and safely storing it while you still need it, accessing the incredible treatment options that we have so close to home, and the outcome can be such an incredibly positive one. And congratulations on the hard work that you've done to come up to 1 year of sobriety. So we're a substance use county in Norfolk County. We don't have gang violence. We don't have a lot of homicides, but opiate overdose and impaired driving, both part of Stephanie's story, are what we need to focus on. And I think that projects like this and efforts at home can really make a difference in both of those issues.
Thank you, Jen. Dr. Falling, do you want to address a little bit how an individual or a family might be able to speak with their doctor about concerns that they have?
Yeah, and thank you for inviting me as well. I have to say I am coming at being a part of this panel, I think, more from the perspective of the audience maybe than the experts. I think that we in primary care are in the process of learning how to deal with this epidemic of disease and overdose deaths, and the Brigham who I work for is in the process of developing policies and procedures. We are the the focal point where patients come with depression, with alcohol issues, with pain, and we are the folks who often are filling the prescriptions for people with pain and dealing with acute pain and chronic pain, and we are working on figuring out how to do this in as safe a way as possible. I think in terms of depression, and I think in terms of alcohol addiction, we have long had sort of standard screening for problems, and for, I think, narcotic use, much less so. I think that we are just in the process of trying to learn and disseminate some of this information that I have heard. I think Stephanie's story is, I mean, it's amazing in terms of the moment that you had an opiate in your system and how much control over that it had instantly is really very instructive to me in terms of thinking about patients who are using pain medication and how it reacts. And I heard something that I wasn't actually aware of, and I'll just clarify. If you're a family member and you're worried about opioid overdose, you can get naloxone without a prescription, without my involvement, just by asking.
Yes.
And that's something that I did not know. And I can say that for our patients who are at higher risk of overdose because of chronic pain, we are just starting to suggest to them and family members that naloxone is available, and give them instructions on how to use it. And the one thing with naloxone is that if naloxone is used and a patient gets better, you still need to call 911.
Glad you brought that up.
Because these medications can be, these substances can be in your body longer than naloxone will protect you. So in terms of talking to a primary care doctor about substance use in general and opioid, I was wondering if, Stephanie, were you ever asked that by a doctor? And do you think that before you entered recovery, was there anything that we could have said to you, or if we asked? My one experience, I would say, with substance, with screening, is you have to ask, and you have to be very specific with your question. And I'm curious if that was ever done, or.
Well, and when my addiction was really full force, I avoided doctors, obviously. But in the beginning, when and with my pill use, I was always nervous, like thought they were gonna find out, or like I lied about my drinking, like when I was asked, like, do I drink? And I would lie about how much I drank, but I did approach my old primary care physician and told her that I did have a substance abuse problem years ago. And she knew, but I thought more, this is a long time ago too, I felt like more could have been done. I don't know, maybe she could have helped me with resources of where I could have gone, whether it was like, addiction specialist or something like that. So unfortunately, not a whole lot was done, but also I did avoid like primary care physicians for a while, just because, I didn't really want to know what was going on with me. So, I mean, I definitely think some more could have been done, but I mean, this was, 10 years ago, so more than that, 15 years ago, maybe even, like when I expressed to the doctor. But I wish she maybe would have asked, maybe asked me exactly what was going on, because, I had expressed to her that I was on Suboxone, and she didn't really say too much about it. So yeah, unfortunately, I mean, it happens, I guess, you know, like.
The other thing that in your story that I found very hopeful is that there was a number of attempts and failures and attempts again, and the fact that you failed at one point in time didn't mean that you shouldn't try again. And I think
Yeah, no. It was, I mean, especially after the first time I tried, you know, to get sober, I had more after when I relapsed the first time, it happened to me more and more where I had moments where I knew I needed help, where I knew this needed to stop, and I could not live like this any longer. It was closer, you know, and there were moments like that were closer together than before. Before I just like lived my life like with my eyes closed, you know what I mean? I just, like I said before, I thought like, this is my life, this is how it's gonna be, you know? But once I did learn a lot more about the disease and everything of addiction, alcoholism, and after I had relapsed and like I learned of like the insanity of it and how, you know, I just couldn't stop, and it was constantly on my mind that, I knew I wanted it more than anything. So I didn't stop.
and I think from a perspective of families, we certainly have had patients in our practice who have had opioid addictions and some who have died, and we've had families who I've known and tried to help, help their family members, and I think that's definitely an area where talking to your primary care doctor and helping a family member with addiction requires help, and it requires teamwork. I mean, it's more than the primary care doctor can do, but in our office we have a wonderful social worker, we have wonderful addiction psychiatry, resources. So the resources are there, and your primary care doctor can be an avenue in terms of accessing those resources. I think your story of the intervention is a great example of that. That takes a lot of planning for families, and
they did a lot of. My parents did. Sorry to interrupt. They did a lot of research about treatment facilities, and I believe they got some sort of help, whether it was through maybe like a website, but it was some sort of for families with somebody suffering from addiction, of how to handle the intervention and what to say, and then they had a place ready for me to go to, and had them on the phone like ready for me to like talk to them once I decided like I would go. It was a lot of planning for them. I never really thought about that. Thank you. I mean, I could imagine like it probably. Yeah, they did a lot of work for me. Yeah.
And that wasn't the moment of your story that you became sober, but
No.
but it was a step. And
yeah, it was definitely a step. No, that place definitely helped me. I was not ready at all. I wasn't ready. I know that sounds crazy, but sometimes people just don't hit low enough, or they're, but thank God it was before anything happened to me. I wasn't ready, but it absolutely helped. Going down to that treatment center in Florida, it educated me more, and understood why I was feeling the way I felt, like mentally, emotionally, physically, and all that. And I'm grateful for that. I'm very, very grateful for that, because I wouldn't be here now if that didn't start my journey in like recovery or like sobriety. Like I wouldn't be. So it's a big part of my story.
did you, when you were abusing prescription opioid pills, did you buy those off the street, or did you
Yeah.
ever find them in other people's medicine cabinets, or
A little bit of everything.
Yeah.
Well, the first time I was prescribed them, I broke a couple ribs, and the pain was really bad. And when I was prescribed the prescription opiates, they worked. I remember how well they worked for the pain because, like, I played sports in college, and they worked really well. And then I think because they started to heal, you know, and I remember I took one day and I was like, oh, like, because instead of it going to the pain, because there was no more pain, it just went to my head, and I remember the feeling. So it was definitely like whether prescribed, but then mostly it was like from the street, and I'm sure I've rummaged through people's medicine cabinets. You know what I mean? I'm not going to talk about that.
Yeah. I think in geriatric medicine, when we don't know what people are taking, we do what we call the brown bag visit, and we have people take all the medicines they have and put them in a bag and bring them in. And I can tell you that probably most of us are more like the geriatric patient. What goes in the medicine cabinet stays there forever. And we touched upon this, but there's a lot of opioids left over from procedures, and part of the law you touched upon is we're really making an effort to not overprescribe for procedures acutely opioid medications. But I think that those medicines are there for kids to find, for the friends of your kids to find, and you should look in your medicine cabinet, find them, and bring them and dispose of them.
Could you give for the audience the names of some of the opioid medications that are legally prescribed by doctors? Just because people might be thinking, well, I probably never got that, but they probably did.
Oh, yeah.
Sure. I mean, oxycodone is the generic ingredient in Percocet. Vicodin is hydrocodone. A lot of it's generic now. Those are the stronger opioids that are out, but also there's codeine, Tylenol with codeine. There's cough syrups with codeine that have a lot of narcotic. There's cough syrups with hydrocodone that are very, very strong. Look for those names. And
Yeah.
One thing I wanted to add that we see at about 40% of our overdose scenes is a drug called gabapentin, also on the market by the brand name Lyrica, and also Neurontin, another name for that drug. So that it's not scheduled in a way that really allows doctors to be vigilant about patient access. And in the last numbered section of Chapter 52 of the Acts of 2016 speaks to gabapentin because of its prevalence at overdose scenes. So that's a drug that if someone you love is struggling with addiction and that's being prescribed to them, or that I believe that it has been presented to physicians as being a safe non-opioid alternative to diabetic neuropathy, and unfortunately, it is used in a way that enhances the high of an opioid and further, depresses respiration, and that combination is what we're seeing in a lot of our fatal overdoses. I also wanted to say that a lot of the drug seeking that we see isn't to a trusted, known physician, your primary care physician. It's in environments where drug seeking is easier, like an emergency department or a minute clinic, where you don't have a relationship with the physician who knows you and who knows your family and who knows your medical history and who's known you since you were a little kid, and because that wouldn't be the kind of person that would be fooled by something you were saying if you were a patient who was seeking medication in that way. So our more drug-seeking rich environments are in those environments where you don't have someone who's providing your care, who's a regular part of your health care. And I also wanted to add, too, that one of the greatest challenges that I see is information sharing in this issue. So this is highly sensitive HIPAA-protected information, and what was staggering to me to learn as a prosecutor was that, we're expecting physicians to change how they're prescribing, yet there's no mechanism that lets a physician know if their patient has died of overdose. And so how can we truly expect someone to change what they're doing if they don't know that those combinations of medicines are, contributing or causing death? And so one thing that I neglected to mention but wanted to make sure that I did was that we're holding a safe prescribing and dispensing conference for all who prescribe and dispense medication in Norfolk County, really to be transparent with our data so that you don't have to have a patient die and have us refer you to the Board of Registration in Medicine or Pharmacy to learn what we're seeing in those medication combinations and so forth. You can come to the conference. It's in September. Information is up on our website. And we want to share that information so that those who are making those really important decisions about, handing someone a prescription for something like Vicodin or Percocet or oxycodone can do that, knowing what we unfortunately know from looking at fatal overdoses.
Can I add something? I mean, from my side of it, like when I walk into a doctor's office, like it's known now, like I am not to be prescribed any sort of narcotic or opiate. I made that decision myself years ago. When I told my primary care physician, I was like, no, like now it's everywhere. Like I think of him in the system, that as an addict or as an alcoholic, like I will not be prescribed. But also people are really, addicts, alcoholics are really afraid. They're fearful. Sometimes even like with their regular PCPs, or like I was even like afraid to tell Dr. Twark or my therapist when I'd relapsed. You know what I mean? It's like there's so much shame and guilt going in it. Like they don't always tell their primary care physician because there is a huge like stigma, and because we have been treated differently when we say that, when we're on certain prescriptions, or when we say that we're an addict or an alcoholic. Like it has happened to me before. It has happened to me with physicians like that. I'm just being honest, it has happened. Whether it's at the pharmacy, whether it's at a nurse somewhere, or it's in a hospital, when I've gone to hospitals because of my addiction for whatever reason, and the way I'd been treated by a doctor, or because I was just the addict, junkie, excuse my language. And I have been treated like that before. So, and then that's why, one of the things that bothers me when it comes to it is just the stigma. And like you said before, I come from a great family. I have great parents. I was raised right. This happened to me because, I truly believe I was born like this. I'm an addict. A switch was flipped in my brain one day, and this is what happened. And that the picture of an addict isn't just like somebody on the street, some disgusting bum on the street with a needle sticking out of his arm. It's like your daughter, it's your mother, it's your brother, it's your sister, it's your best friend. You know what I mean? It's things like that. So I just, I just wish the world would see it in a different view is all, and making it easier to talk to doctors and nurses and cops, whatever, anybody, I don't know. That's all.
One thing that we've sort of seen a lot, and really trying to share the message, and we have two physicians here that I don't know if they've ever had this experience, but our most vulnerable population are those over age 18, and their parents aren't able to get information about their health care. But there's nothing that prevents a parent from connecting with, say, Campus Health if your child is in college, to say, my child has struggled with addiction. You need to know that because my child shouldn't be prescribed, these medications. And there would be nothing, you can't get any information back. But there's nothing that prevents you from contacting those who are providing care to your adult children. In many of our overdoses, the kids are living back at home. These are individuals in their 20s and 30s living at home, sometimes with their children, and yet there's nothing that prevents you from sharing that information and making that phone call. So,
Agree. We would never share personal information, but we can listen to it.
Right.
That's not share. That's nothing wrong with
and
that.
help it guide
You
your
can
own,
listen.
help you understand something that your patient might be struggling self-disclosing.
And I'm struck by that there is a lot of time and there's a lot of people who are dealing with addiction who aren't sober, and that is part of their health care, and we need to be able to take care of patients who are actively drinking, actively using. That's part of their medical problems, and it should be like any other medical condition.
Any other chronic illness, right? Claire, do you want to speak a little bit about some of the initiatives you started? I know you've been talking about training physicians and things.
Sure. I really appreciate the opportunity to be here, and it's been a privilege to have the chance to work with Stephanie in her path to recovery. I think, like Jen mentioned, the statistics aren't quite as powerful as Stephanie's story, but I did take a slide from the mass.gov website showing the really alarming increase in unintentional overdose deaths related to opioids, especially beginning in 2012. You can see that the numbers have really been rising significantly. This slide only goes up to 2015, but unfortunately the problem is really still continuing. So as a resident at Brigham and Women's Hospital, I've had the opportunity to work with addiction psychiatrists there and see a lot of the things that we've been trying to do at the hospital to address the opioid crisis. So examples of that include trying to train more physicians in being able to prescribe buprenorphine, one of the medications used to treat opioid use disorder. So simply holding more buprenorphine training courses is an important part of that. In order to prescribe buprenorphine, you need special certification to do so. And so one of the barriers to getting that certification is to get the coursework out of the way. And we've been marching that buprenorphine coursework earlier and earlier in the medical process. So it used to be something, I took it as a third-year psychiatry resident, and now they've moved the course even earlier so that our medical students are actually taking the course. And so they'll have that part of the work done long before they're even eligible to get that prescribing ability. So just getting people on the track to be able to prescribe buprenorphine earlier. One thing that's been really amazing to see and participate in is doing buprenorphine inductions at Brigham and Women's Hospital, right in the hospital. And so what we'll do with the other physicians taking care of patients is we'll ask them to automatically call the addiction psychiatry team anytime a patient has something called endocarditis, which is an infection of the heart valves that can result from injection drug use. And so these are patients who've presented to the hospital because they've had fevers, they're having shortness of breath, they're having symptoms that are from this endocarditis, the heart valve infection. They're not coming to the hospital asking for substance use treatment, and a large proportion of them are actually willing to start buprenorphine in the hospital, and that way we're getting them into treatment before they're even discharged from the hospital. Not every hospital in the country does that. It's a really unique thing that we've been doing, and it's amazing to see. I'd say probably the portion of substance users that a lot of people would think are not interested in treatment, people who have really severe infections and sequelae of their drug use are still willing to engage in treatment and start treatment even in the hospital. One of the other points that Jen mentioned, as a physician, being mindful of the effects of combining different medications when I'm prescribing to someone. So it's been really important to learn how to use the prescription monitoring program, which is a database of pharmacy records that keeps track of a lot of medications that have misuse potential. Not every state participates, but a lot of states are on this universal prescription monitoring program. And so I can search a patient's name, date of birth, and choose all the states, and the default, it'll go back over a year of time, tell me how many prescribers that patient has had, the number of times the patient has paid for a prescription out of pocket rather than with their insurance, how many pharmacies they're using. So a lot of just quick ways of seeing, are there some warning signs here? Are there multiple sedating medications that this patient has filled all in the past month? Are there multiple prescribers prescribing opioids and benzodiazepines? And so training physicians how to not just remember to look at the prescription monitoring program, but also interpret the data in the prescription monitoring program. And a lot of the time I'll actually open that when I'm in an appointment with a patient. I think some providers see it as something that is taking a lot of time to do, and some of us will actually just incorporate that into our appointment with patients so that we remember to check it. And that's an extremely important step, I have to say. What else? I think another interesting part, and one of the things that I like so much about treating people with substance use disorders, is the mentality that you must have when speaking to substance users. So as Stephanie mentioned, there's a lot of stigma and there's a lot of judgment when it comes to substance use, even amongst medical providers, unfortunately. And there's a style of interviewing called motivational interviewing that is starting to be taught even in medical schools and in residency programs. It's not unique just to substance use. It's helpful when you're trying to convince someone to lose weight or be more adherent to their insulin when they have diabetes. It's a very patient autonomy centered approach. It's a very non-judgmental approach, and I've found that it just gives me a go-to toolkit when I'm speaking with patients on the spectrum of readiness to change regarding their addiction, from people who really haven't thought of it until I come to talk to them, to people who are ready to engage and start treatment. Speaking of treatment, I wanted to speak a little bit about some of the medications that we've been talking about, and if it's possible to go to the next slide. So just for orientation, this slide is organized by what we call the mechanism of action of these medications, so the way that the medication works. So on the left, I listed a few of the opioids that we've been talking about. So heroin, which interestingly used to be a prescribed medication and is named heroin because it was felt to be a heroic treatment for morphine addiction. People at first were realizing, if we give people heroin, they stop using morphine. Well, yes, and then came heroin addiction, unfortunately. So other prescription opioids that are still being prescribed by physicians today, things like morphine, oxycodone, fentanyl. And then methadone actually is a treatment for opioid use disorder. It's in the same category of medications that fully activate the opioid receptor in the brain. So these red diagrams below are a schematic representation of an opioid receptor in the brain. The actual molecular structure is much more complicated than this, so it's just a cartoon version for the sake of explaining a point. So all of those medications on the left, they bind to the receptor and they activate it fully. We call these full agonists. So you might find yourself wondering, well, if methadone is a treatment for opioid use disorder, why does it have the same exact mechanism of action as the other opioids listed there? So methadone is, when it's used for opioid use disorder, is a federally regulated medication. So only methadone clinics can dispense it, and they generally dispense it on a daily basis. So patients in treatment at methadone clinics have to go there for the most part every day. Sometimes they can earn the ability, if their treatment is going well, to have some take-home doses. But for the most part, they go there on a daily basis. So there's a very controlled environment in which this medication is being administered. And methadone has been shown to keep people in treatment compared to people who are not on methadone. It's been shown to decrease mortality rates, decrease risk of relapse. So some people consider it kind of a harm reduction approach, we might call it, but has definitely been shown to still be very beneficial when used in this very structured environment. So in the middle section, that's where buprenorphine belongs. So that's the name of the active medication in Suboxone, which a few of us have mentioned already. So this category of medications is what we call partial agonists, meaning they partially activate the opioid receptor. So they bind to the same receptor as the full agonists, but they only activate it part of the way. And the most important part to know about buprenorphine is that the opioid receptors actually prefer buprenorphine compared to the full agonists. So that's very important when we're choosing the timing of starting buprenorphine, because, I won't go into the details of that, but basically, once someone is on buprenorphine, which a lot of people will describe as, who are opioid dependent, will describe being on buprenorphine as feeling normal again. So not something that brings on euphoric effects like heroin. If someone is being prescribed buprenorphine, taking it as prescribed, and then they try to inject heroin on top of it, because the opioid receptor prefers the buprenorphine, they'll notice that they won't get the same high from the heroin. And that's why it's such an effective treatment for opioid use disorder. On the right is the medications that are what we call opioid antagonists, or they actually block the opioid receptor. So one of them I actually brought with me, and to the point of the standing orders at the pharmacies, I actually picked this up from the CVS right down the street in Foxborough before I came here. So I didn't ask a physician to prescribe this to me. I didn't write myself a prescription for it. It's just a standing order that's at the pharmacy. And they've actually increased the dose of naloxone because of the stronger opioids like fentanyl that are now being used. So now there's 4 milligrams in this nasal spray, and you don't have to assemble the older naloxone kit. You had to assemble it, so it's much simpler now. And you simply press the dispenser into one nostril, obviously call 911, and then there's 2 per kit. If the person isn't responding within 2 or 3 minutes, then the recommendation is to give the other dose. So this being, I was excited to try out this standing order that I've heard about, and it's true. You can find it right at the CVS here in Foxborough. So naloxone is something that would be used just acutely to try to reverse an overdose. Interesting with some of the stronger opioids like carfentanil that you mentioned, and fentanyl overdoses. In hospitals, sometimes not only will the Narcan, the naloxone nasal spray need to be administered, but patients will actually have to receive naloxone infusions. So just drips of naloxone infused into their body because the opioids are so strong. Another thing to be mindful of with fentanyl, and fentanyl particularly, is that when it's being illegally manufactured in places like Mexico and China, it's now being put into tablets that look like the usual prescription opioid medications and even prescription benzodiazepines. So people who are buying tablets off of the street thinking that they're buying a prescription opioid that's, what they're used to, might actually be entirely fentanyl and not have any of what they're used to at all, and be much, much more potent and bring a higher risk of overdose.
Right.
The other medication that I wanted to talk about is naltrexone. So it sounds very similar to naloxone, but it's naltrexone. The brand names of that are Revia and Vivitrol. And this is actually used as a treatment for opioid use disorder. The naltrexone in the pill form is taken on a daily basis. The long-acting injectable form of naltrexone is given usually once every 4 weeks. And that is basically putting a cap on top of that opioid receptor. It doesn't activate it at all, and it prevents other opioids from being able to bind. So that's another option. We, at the Brigham and Women's Faulkner Hospital Addiction Recovery Program, we have both buprenorphine and naltrexone programs that are excellent. I highly recommend them. I've had the privilege of being able to work there once a week for the past year now, and it's amazing. All the groups that are available and the providers who are there are fantastic. I've learned a lot from them. And I hope we've kind of talked about our messages that we each want to pass along. I think addiction psychiatry is the most fantastic area to go into. There's just so much satisfaction in helping people like Stephanie and anyone else out there who's interested in going into medicine, or interested in going into psychiatry. It's an excellent choice. So, yeah.
Thank you. And now, Wenwei, do you want to, Wenwei from Riverside Emergency Services, the place you'd call if you're trying to help someone, you want to talk a little bit about your programs?
Yes, thank you for inviting me, and really, appreciate the opportunity to hear, Stephanie's story, because I think that is very powerful, when, someone is sharing, a personal story, and how they, been through that process, and eventually becoming, recovery is your journey, there's still a way to go, but your story will help others, to have that courage to move forward, and get help, when the timing is right. You have mentioned a lot of important things,
Yeah.
I'm coming from Riverside Emergency Services. We're 24/7, we provide 24/7, service. We always have, trained clinicians in responding to the phones, to provide resources for individual. If you are not ready, but you just want to kind of learn what's available out there, I think that Stephanie had mentioned, you wish that you had known more resources back, or there's more resource available. I think that part of us can act, as that resource, to share, what's available out there, so when opportunity comes, you know where to start, We also provide, face-to-face assessments, in terms of, helping out understanding, what, the person's story, in then recommending what might be the necessary next step, or if they're not ready for this, what other options might be available, right there. Or, in need of time, you really need placements. So we also have that, knowledge and capability to kind of, work with the insurance company, in a sense to, figure it out what's covered and what's not covered, and where to go from there. And besides, Riverside have other programs available, such as what you have mentioned about the outpatient, program in Norwood. That's more specialized in, counseling as well as, psychiatric, medication prescriptions. We certainly, not only provide, treatments for substance abuse, but also for, people struggle with mental health, conditions. And, I just want to piggyback, to, a lot of things that you guys have, shared, tonight, when someone, really struggle with getting help is part of that reason, the stigma, because of stigma, people feel, or in fact have, many cases proven that, it could potentially be mistreated, because knowing you have this condition, doesn't matter if it's addiction or mental health, people will have different reactions to it, unfortunately, among the providers as well, not along with the social environment. If a lot of people who are resistant to get treatment, it's because I don't want the neighbor to know, what our family is going through. I don't want to disappoint my parents, because then, I feel like very, proud of your, parents for, being so supportive in a sense that when they treat you, they are not judgmental. Those are the things that we really, the key things to help people in recovery is, using the non-judgmental approach, because addiction is not a choice. Addiction is a disease. When you are dependent on substance, to get through your day, it's not like you choose literally to do it. It's that had taken your kind of judgment away, and and every day, seeking the next dose might be what you are kind of focused on, not necessarily thinking about anything else. And I think that the stigma also have proven that a lot of times the numbers of people who get treatment is still minimal. There are still a lot of people who are not seeking treatments. And I think that the statistics, talking about, the potential overdose cases are still minimal, because like there are a lot of cases, I think that Mike had mentioned, people who receive Narcan treatment not necessarily agreeing to ride with the ambulance to go to the emergency room. So there's also that data not collected, and I think that it's really important, for people to know that following even the Narcan treatment, going to the emergency room is a methods of more medical observations. And post the observation, when it's deemed medically clear, the Chapter 52 also support that all the emergency room need to offer the individual who just received Narcan treatment as well as, or physician actually suspect someone had overdosed on on substance in opiates overdose, even without Narcan treatment. They're supposed to offer opportunity for a substance use disorder assessment. Because by offering that, it gives opportunity for the individual to know that there are treatment out there, there are resources out there, and in fact, if you want the help at that time, we can also try, because we have worked with Norwood Hospital in conducting the substance abuse assessment. We actually can connect people, based on the resource we know of, to detox treatment or to other, it potentially, we know that people doesn't really need that medical detoxification. They are, treatment like you have mentioned, the IOP, even the partial, hospitalization programs, or, certain times insurance also cover for CSP, which, means is community, support program, provide many, kind of case management to make sure people does follow through with treatment. So there are, in fact, a lot of resources out there, and I think that the past few years, even the state have working really hard to, provide a lot more assistance. And I think that that's the difference you might feel, from years ago.
Oh, absolutely, yeah.
That they're actually, for youth, they are like, the intake, service for youth. We know the number, I guess I didn't include, in the, slide, it's part of, this is what I just learned, that youth actually have a separate intake line that you can call, and they can then talk to you about, different treatment options. They are, detox treatments, they are residentials, they are young adult residential options. There are even recovery high schools, options,
I've heard
which,
about those.
yeah, they will work with store district, to, figure out if that potentially is helpful options, and there is also outpatient, there is medical assisted treatment, so through that, central intake hotline, it's 866-705-2807, and they are able to connect people to the specific youth treatment. And I think that's important to mention that, for youth, there is actually someone who are trained and able to walk the parent through the process and how to get access to those options. And as to adults, the Bureau of Substance Abuse Services actually also provide a hotline for people to call to get, help. The number, I think we have it in the slides,
we
right?
did show the resources,
Okay.
and we will have them available at the end as well. You don't have to read the number out.
Okay.
It's gonna come up on the screen.
Thank you. And then I think that I also want to mention that, through this process, I think that family, parents are usually the one that sees everything, but not knowing where to go, and I think that the local service program called Learn to Cope actually provides support for parents, or family members who have individual they care about struggling, with the issue, There's also one resource I want to mention is called Massachusetts Organization for Addiction Recovery. It's focusing on it's peer support. It's for individuals who are in recovery to support someone who is struggling. I think that Riverside really focus a lot on the the peers. We actually have certified peer specialists who are the individual who kind of go through the process themselves and is in recovery and able to use their personal experience to kind of help people and support people. Wow. I think that's very powerful. Yes. That's why I really thank you for bringing your story forward, because I think that a lot of times provider can tell people about this is what you do, what you need to, but that not necessarily is the most helpful thing. But for people who know, like, oh, I'm not alone. You've gone through this process as well. Yep. Maybe I can pick up. Maybe not that moment you're ready. The next time when they're ready, they know. Last time I have heard this story, this is where I want to go to get help. And the other thing that I know that is very important for you is I'm very glad that first experience of you getting treatment is very positive. I think that we also need to be mindful that when someone comes to us and tell us about their issues, that's their first time really speaking up. And if we use a judgmental tone or a way to interact, that's going to stop them from wanting to seek out help again. I'm very glad that your first experience was positive, because then when you're ready for help, you pick up the phone and ask your family and say, I need help right now. Take me to it. And you were not hesitant about it.
Right.
So.
Well, that's another reason why I went straight to NORCAP. They're a great facility. And they're really helpful there. A lot of the staff themselves are in recovery, and they know what they're doing. It's a great place, so.
I do have a couple of pieces of paper that have been handed to me with comments. One of them, this is so timely because we've all been talking about how a lot of times people feel like Foxborough is, that this isn't a problem in Foxborough. And I actually have something from the Foxborough Police, a press release from today. And it says, Officers Head, Para, Burns, and Sergeant Chamberlain responded to a call for service early Saturday evening for suspicious activity. The subsequent investigation resulted in the arrest of 2 Bellingham men, Mark Patton, 28, and Christopher Landy, 31, who were charged with the possession of over 50 grams of suspected fentanyl. This is believed to be the largest seizure of fentanyl in the history of the Foxborough Police Department. Fentanyl is an extremely potent opioid which has been linked to a large number of fatal overdose deaths in the area communities. The 2 suspects were arraigned Monday morning and pled not guilty at Wrentham District Court on a variety of charges, including drug trafficking, and the police investigation is continuing. Pending charges represent accusations. All defendants are presumed innocent unless and until proven guilty beyond a reasonable doubt under the United States Constitution. And here are some pictures from the Foxborough Police Department that they sent in to us via our live streaming. So that's pretty amazing that this is all happening at the same time. So I think we can all agree that this is a very real crisis that's here in our community. Also, we did have a comment via Facebook for Stephanie. It says, congrats on getting clean and keep up the awesome job. And I think we all agree with that. So thank you, Stephanie. When Steffi and I were talking about setting up this, this program, one of the things that she said was important for her to convey is that there's hope and that people can and do recover. And I hope that that's something that people in the audience have gotten from this program. We are here to help. Our list of resources are available on Foxborough Cable Access website. They'll also be on the town website. We have a PowerPoint of the slides that have been shown here that I will have on the Foxborough Council on Aging and Human Services section of the town website. And I also just wanted to thank all of you for being here and spending all this time. And I also wanted to give a special thanks to Cindy Peterson of Brigham and Women's, who was really instrumental in helping get our panelists together. So thank you all so much, and to Mike and the crew. And I think it's been a great program. Oh, and the other thing I just wanted to mention is that form that you can use to go, like, if you weren't clear and didn't want to, you wanted to hand this written out to the pharmacist because you were embarrassed or wanted to, protect your privacy, these forms are available at the Foxborough Senior Center. They're at Town Hall. They're at the Boyden Library. There are some churches that have announced this on Sunday, and they have the forms available in their lobby. There are some at Brigham and Women's on the table in the front lobby. And with it, there's also an instruction sheet that tells you how to avoid an overdose and then what to do when someone has overdosed, as far as calling 911, making sure the airway is clear,
Yeah,
and
I think
all
one
of
thing
the other
we
instructions.
really want to recommend strongly is that if people do take Narcan and have it in their home, that they do have CPR training. I think
Yes.
they really go hand in hand.
Yeah.
So I think that's something we need to stress more too. It's that the Narcan's not a magic bullet. It takes time, and really it's a medical emergency, and those people need to be managed medically.
Right.
So when someone does get Narcan, they do, a lot of times they're in respiratory arrest or cardiac arrest. So, and Narcan's not effective if you're in cardiac arrest.
And I think
Really,
you did-
CPR is a
You
treatment.
did mention when we were, had another meeting that sometimes people think it's like they use Narcan and it's instantaneous, and
Right.
it does take a few
It's like in the
minutes to
movies,
take
yeah.
effect.
There's multiple ways to give Narcan, and the most
Nasal.
easy way is the nasal, and it's going to be absorbed into the system. If your system's depressed because of overdose, it's going to take a long time for it. When the paramedics get there, they give it IV, and it's instant. It's like the movies. People wake up within seconds. But the nasal Narcan that's prescribed by the pharmacies and given by civilians is not. It's
Takes
not
a
as
little
fast
longer.
acting, and things like fentanyl, as we mentioned, people need to be managed for days sometimes medically. So I think that critical is CPR training for these people, and calling 911. Don't try to manage these people on your own, at home. And we fall under the same HIPAA rules and everything. We're medical providers downstream, so there's privacy and everything that we do as well. We're bound by all the same laws as the physicians.
Okay, well, thank you very much for being here. And as I said, our resources will be available. The show will be repeating on Foxborough Cable Access. If you want to go to fcatv.org/opioid, you'll be able to see our program again if you missed anything. So thank you very much for joining us, and thank all of you, especially